Dear healthcare professionals, today in this video I am going to present few more questions related to EDIC part 1. Mainly I will be focusing on antibiotics, infection, antibiotic stewardships and MDR organism and so on so forth. So let's begin.
Question 1. A 28-year-old man presents with high-grade fever, abdominal pain, vomiting, and bleeding gums. On examination, BP 80/50 mmHg, heart rate 120 per minute, cool peripheries, narrow pulse pressure. Platelet count is 25,000. Hematocrit has increased by 20% from baseline. What is the most appropriate initial management step? Rapid infusion of 20 milliliters per kilogram normal saline over 15 to 30 minutes. B. Immediate platelet transfusion. C. Start norepinephrine infusion. D. Intravenous dexamethasone. Broad-spectrum antibiotics. Correct answer is I. Rapid infusion of 20 milliliters per kilogram normal saline over 15 to 30 minutes. Explanation. This patient has infection associated with hypovolemia likely due to dengue shock syndrome, characterized by plasma leakage causing hypovolemic shock with hemoconcentration and thrombocytopenia. Initial management is aggressive isotonic crystalloid resuscitation, normal saline or Ringer's lactate 20 milliliters per kilogram bolus. Platelet transfusion is indicated only if active bleeding or platelet less than 10,000 without bleeding. Vasopressors, norepinephrine, are added only if shock persists after adequate fluids. Question 2. A 68-year-old man with severe pancreatitis has been on mechanical ventilation for 9 days in the ICU. He was initially treated with piperacillin, tazobactam for intra-abdominal sepsis. He now develops fever, 39.2 degrees Celsius, increasing purulent endotracheal secretions, and rising oxygen requirements. Chest X-ray shows new right lower zone consolidation. Quantitative endotracheal aspirate culture yields more than 10 to power 5 CFU per ml of Pseudomonas aeruginosa resistant to piperacillin, tazobactam, ceftazidime, and ciprofloxacin, but sensitive to meropenem and amikacin. Which of the following is the most appropriate antimicrobial management strategy in this case? Start high-dose extended infusion meropenem monotherapy for 7 days. B. Use meropenem plus amikacin combination therapy, reassessing for de-escalation once clinical stability is achieved. C. Administer meropenem plus intravenous colistin as it provides maximal coverage against MDR Pseudomonas. D. Meropenem and colistin nebulization for broader coverage. Use nebulized colistin with intravenous amikacin to limit systemic toxicity. Correct answer is B. Use meropenem plus amikacin combination therapy, reassessing for de-escalation once clinical stability is achieved. Explanation. This case represents ventilator-associated pneumonia due to multidrug-resistant Pseudomonas aeruginosa. For severe Pseudomonas aeruginosa infections, especially in critically ill or immunocompromised patients, current guidelines and studies often recommend initial combination therapy with 2 active agents from different classes, an antipseudomonal beta-lactam and an aminoglycoside or fluoroquinolone, to provide maximal bacterial killing, potential synergy, and prevent the development of resistance during therapy. Monotherapy may be considered after 48 to 72 hours of clinical improvement and confirmation of susceptibility to minimize toxicity. Extended or continuous infusion beta-lactams improve pharmacodynamic exposure, time above minimum inhibitory concentration, particularly in severe sepsis or high-volume distribution states. Colistin is typically reserved for highly resistant Pseudomonas aeruginosa strains like carbapenem-resistant, when other options are unavailable given its nephrotoxicity and suboptimal lung penetration. Question 3. Which of the following correctly matches the predominant mechanism of resistance and inherent resistance pattern for these pathogens? Acinetobacter baumannii, resistance mainly due to OXA-type carbapenemases, intrinsically resistant to colistin. B. Klebsiella pneumoniae, resistance mainly via KPC-type carbapenemases, intrinsically resistant to ampicillin due to chromosomal beta-lactamase. C. Pseudomonas aeruginosa, resistance primarily by ESBL production, intrinsically resistant to aminoglycosides. D. Stenotrophomonas maltophilia, resistance mainly via NDM1 carbapenemase, intrinsically resistant to trimethoprimsulfamethoxazole. Acinetobacter baumannii, resistance primarily by efflux pumps alone, intrinsically resistant to carbapenems due to loss of porins. Correct answer is B. Klebsiella pneumoniae, resistance mainly via KPC-type carbapenemases, intrinsically resistant to ampicillin due to chromosomal beta-lactamase. Klebsiella, KPC and NDM are major acquired carbapenemases, intrinsic resistance to ampicillin. Acinetobacter, OX-type carbapenemases plus efflux and porin loss drive MDR or XDR phenotype. Pseudomonas, resistance is complex, involving porin loss, AMP-C induction, and efflux pumps. Stenotrophomonas, intrinsically resistant to most beta-lactams and carbapenems. Trimethoprim-sulfamethoxazole remains the drug of choice. Question 4. A 43-year-old woman presents with septic shock secondary to acute pyelonephritis. Urine culture shows ESBL-producing Escherichia coli. What is the most appropriate initial antibiotic? A. Piperacillin-tazobactam. B. Cefepime. C. Meropenem. D. Tigecycline. E. Ciprofloxacin. Correct answer is C. Meropenem. Explanation. Carbapenems, meropenem, imipenem, ertapenem, are generally considered the antibiotics of choice for the treatment of serious infections, including septic shock, caused by ESBL-producing Enterobacteriaceae. Piperacillin-tazobactam has shown inferior outcomes compared to carbapenems in treating ESBL bloodstream infections and is generally not recommended for invasive ESBL infections, especially in critically ill patients, even if the isolate appears susceptible in vitro. Cefepime is a fourth-generation cephalosporin but is often ineffective against ESBL-producing organisms and is not recommended for treatment of ESBL infections, even if it tests as susceptible. Tigecycline is an alternative for non-critically ill patients with adequate source control, but is not a first-line agent for septic shock. Ciprofloxacin resistance rates among ESBL-producing E. coli are often high, over 50%, and it is generally avoided for empiric therapy in severe cases due to the risk of treatment failure. Question 5. Regarding antibiotic stewardship in ICU, which is most appropriate? Empirical broad-spectrum antibiotics should be continued for at least 10 to 14 days to prevent relapse in critically ill patients. B. De-escalation to a narrower spectrum agent after 48 to 72 hours based on cultures is recommended to reduce selection pressure. C. Routine combination therapy should be maintained even after sensitivities are known to prevent emergence of resistance. D. Antibiotic cycling and rotation policies have consistently shown mortality benefit and are core components of ICU stewardship. Procalcitonin and CRP trends should not be used to guide antibiotic discontinuation, as they lack evidence in ICU infections. Correct answer is B. De-escalation to a narrower spectrum agent after 48 to 72 hours based on cultures is recommended to reduce selection pressure. Explanation. De-escalation, narrowing or discontinuing antibiotic therapy once microbiological data are available and the patient improves, is a core ICU stewardship principle. It reduces antimicrobial resistance, toxicity, and cost without increasing mortality. Typically assessed after 48 to 72 hours, when cultures and clinical response are available. Procalcitonin can help guide duration and discontinuation of antibiotics in ICU infections, supported by several RCTs and meta-analyses. Combination therapy may be justified initially in severe sepsis or high MDR risk, but should not be continued once the pathogen is known and susceptible to monotherapy. Question 6. A 34-year-old male from Sri Lanka presents with fever, myalgia, jaundice, and renal failure. What is the most likely diagnostic clue? Thrombocytosis. B. Elevated CK with myositis. C. Severe hemolysis. D. conjunctival suffusion. Splenomegaly with leukopenia. Correct answer is D. Conjunctival suffusion. Explanation: conjunctival suffusion, redness without exudate, is a classic sign of leptospirosis. Jaundice in leptospirosis is typically due to cholestasis and liver dysfunction, not primarily severe hemolysis. Question 7. A 58-year-old diabetic man presents with rapidly progressive pain, swelling, and dusky discoloration of the thigh. He is hypotensive and febrile. Crepitus is palpable. What is the most appropriate next step? Start high-dose intravenous penicillin only. B. Begin intravenous vancomycin and clindamycin, urgent surgical exploration. C. Obtain MRI before surgery. D. Initiate intravenous ceftriaxone and metronidazole. Administer intravenous immunoglobulin with broad-spectrum antibiotics. Correct answer is B. Begin intravenous vancomycin and clindamycin, urgent surgical exploration. Explanation: necrotizing fasciitis is a surgical emergency. Early aggressive debridement is crucial. Broad-spectrum intravenous antibiotics are essential and should be started immediately to cover common causative pathogens, polymicrobial in about half of cases, including gram-positive, gram-negative, and anaerobic bacteria. A regimen covering MRSA, vancomycin, daptomycin, and gram-negative RODS anaerobes is indicated. Clindamycin is often included due to its antitoxin properties, which can mitigate the severity of toxic shock syndrome. Urgent surgical exploration for debridement of all necrotic tissue is the cornerstone of treatment and the single most important intervention. Delay in surgical management significantly increases mortality. Question 8. A 64-year-old man is intubated for severe community-acquired pneumonia. Bronchial aspirate culture grows methicillin-resistant Staphylococcus aureus with a vancomycin minimum inhibitory concentration of 2 microgram per milliliter. The patient remains febrile and hypoxic despite 72 hours of vancomycin therapy, trough 18 microgram per milliliter. What is the most appropriate next step? Continue vancomycin for 7 more days. B. Switch to daptomycin. C. Switch to linezolid. D. Add rifampicin to vancomycin. Use ceftaroline plus clindamycin. Correct answer is C. Switch to linezolid. Explanation: in a patient with severe MRSA pneumonia, a vancomycin minimum inhibitory concentration of 2 microgram per milliliter is associated with a higher risk of clinical failure, even when adequate trough levels are achieved. The recommended alternative for MRSA pneumonia is linezolid. Linezolid has better lung penetration than vancomycin, and some studies suggest it may be superior for MRSA pneumonia, particularly in cases with higher vancomycin minimum inhibitory concentration. Ceftaroline can be considered as an alternative, but linezolid has stronger evidence for improved pulmonary penetration and outcomes.
Dear doctors, here I finish. I believe these questions were useful to you. See you in my next video. Till then, bye and take care.